You know that boy looks like someone who has seen a lot of breasts in this. So push it up very well so that it will attract his attention.
Why the next day I had to
So far, the surut.
Mr. Ladi, you can go.
Okay.
Chief, you don't reach 83. No, 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 no. No, 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 no. 84, 85.
Good evening. My name is Dr. Mini Oseji. I'm the National President of Medical Women's Nigeria. I'd like to welcome all of you to this day 2 of the MWAN, CME on prevention, treatment of pre-malignant lesions of the cervix. We would like to welcome Professor Jonah Musa, who is going to give us the first presentation on prevention of cervical cancer. Professor Jonah Musa, you're very welcome.
Thank you very much. Still a lot of background noise, so
yes, let me mute everybody and then unmute you because it's taking me so long to mute them one by one. Prof, you can unmute now.
okay, thank you.
Thank you.
Okay, so can I go on now?
Yes, you can.
All right, thank you. So once again, thank you, Madam President, for inviting me to be part of this meeting. And I'll be focused on prevention of cervical cancer. And I'll come up with a, excuse me. So I have these objectives. I will briefly highlight the global burden of cervical cancer and then summarize the factors known to be responsible for the high burden of cervical cancer globally, particularly in sub-Saharan Africa, where Nigeria is part of. And then I will move into the main talk, which is the evidence-based interventions for prevention. And as we're talking about prevention today, we can't discuss prevention without mentioning the WHO initiative of elimination of cervical cancer. And then I will end up with the benefits of prevention of cervical cancer as something that policymakers and all of us need to understand in order for us to do enough advocacy for preventing this cancer. So as I mentioned yesterday, and many of our former speakers have alluded to this, that cervical cancer is one of the commonest female cancers globally. And it is second only to breast cancer in women. And if you look at the numbers, even in Nigeria, the same thing applies. And the sad aspect of it is that this cancer is entirely preventable. It is a disease or a cancer with well-known natural history. We know what causes it. It has pre-cancerous stages, as we discussed yesterday, that are detectable and can be treated. So once we do that, you know, we have prevented cancer from developing. The other thing is that the cervix itself has a favorable anatomical location that lends itself, you know, accessible for examination, you know, and we can easily detect these conditions and treat them, as we have been told severally. And significant decline in incidence have been recorded in settings with organized cancer screening programs like US, in Europe, Australia, and many other areas where they have organized cervical cancer screening program. So therefore, we keep wondering why we see these cases of cervical cancer every day. And as I do share with people, there's hardly any week that I don't have 1 or 2 invasive cases of cervical cancer waiting for for treatment in my practice here in Jos. So in terms of the global estimates of this cancer, and this it was published in the Lancet Global Health 2018. And if you look at it, the message here is that most of these cancers, based on the age standardized incidence ratio, is more concentrated in sub-Saharan Africa. But if you put it together globally, there were over 570,000 new cases of cervical cancer reported in 2018. This paper was actually published in 2020, but it was these statistics were pulled together in 2018. And over half of those numbers will die within the first year of diagnosis. And if you look at, again, the areas with the red coloration here, is mainly sub-Saharan Africa, where our country, Nigeria, is here. So, but if you look at it, the density of the color here speaks about the number of the incident, the age standardized mortality ratio. So the same thing with the incident ratio. So if you look at it, 300,000 deaths occur. It means that if you calculate what we call mortality incident ratio, it will give you about 58%, meaning that every year, this number of patients that are diagnosed every year, about 58% of them will die within the first year of diagnosis. That is what mortality incident ratio means. And again, I decided to bring this and also calculate the mortality incident ratio to further stress the fact or the need for us to invest in prevention. Because if we don't prevent the disease, once they move to the stage of invasive cancer, mortality is very, very high. And we'll look at that when we come to look at the survival data we have for Nigeria. Yesterday, I shared this slide just to tell us that 9 in 10 cervical cancer deaths worldwide occur in low and middle income countries. And it is very easy for you to agree with that distribution looking at just this map. If you look at the areas here, North America, if you go to Europe, Northern Europe, and Australia, most of those areas that have organized cervical cancer screening with prevention services, HPV, DNA testing, as well as HPV vaccination, you see most of those areas are green, all right? And if you come to South America here, there are a few areas, this is Brazil and other areas where they have made a lot of progress. So this is another very interesting map showing the relationship between HIV incidence in Africa. So if you look at the sub-Saharan Africa belt, that is where we have the high burden of HIV/AIDS. And if you look at it, if you interpose this map on this, you will see that there is a correlation, all right? There's a spatial correlation, autocorrelation between HIV incidence as well as cervical cancer incidence. And this, from the outlook, just tells us that there's something related to HIV burden, and cervical cancer. And recently, in December 2020, this publication came out in the Lancet Global Health, looking at estimates of the global burden of cervical cancer associated with HIV. And when they did their own analysis, the message there is that the relative risks for cervical cancer for women living with HIV is 6.07. So meaning that women who have HIV are 6 times more likely to have cervical cancer compared to women who are HIV negative. That is the message I want to show on this particular publication. So when you look at the summary of the factors responsible for cervical cancer in sub-Saharan Africa, one, HIV infection is one of it. The second thing is that there's lack of organized cervical cancer screening programs. And then there is poor coverage, even when screening is available. And if you look at it in Nigeria, most of the screening that is available is opportunistic. That is, if a healthcare provider sees someone at risk, you recommend, or the woman becomes aware that there's a screening service and she has the need to screen, and then she goes for the screening. That is what opportunistic screening stands for, compared to organized cervical cancer screening, where there is active invitation. You send a mail or text message or phone call to women that are due for screening. In Nigeria, we don't have that, and most of sub-Saharan Africa, we also do not have. We also have the problems of illiteracy, weak healthcare system, and then as we speak today, there is no national vaccination coverage for human papillomavirus vaccination in Nigeria. I know the Ministry of Health and other organizations are making a lot of efforts to see how they can bridge this gap and initiate the administration or increase the availability of human papillomavirus vaccination in Nigeria. But as we speak today, there's no national coverage for that. So why is prevention so important in Nigeria? That is the topic of what we are discussing today. But we need to first see why we need to invest in prevention in Nigeria. Now, this data may not represent the entire problems or cervical cancer survival nationally, but this is data that we collected in Jos on the plateau. I have also looked at literature, look at what was published people around Nigeria, Rose Anolu in Lagos and many other areas. The story is not different. And if you also compare the survival with what was published by one of our colleagues in Kenya, the same similar statistics. So what is the message here? Over 70%, precisely in our own cohort here, we recorded that 72% of patients who were diagnosed with invasive cervical cancer in Jos were at advanced clinical stages. And when you look at it, for those who have advanced clinical stage, if you look here, this is advanced and this is early. Compare the probability of survival. You can see the Kaplan-Meier showing rapid decline in survival within a short period of time. And when you look at the probability of surviving beyond 2 years from this very graph, you'll find out that it is less than 0.2 for those on late stage, meaning that if we have patients, 70% of patients diagnosed at late stage, the probability of this cohort surviving beyond 2 years is less than 20%. So about 80% will have died of this disease before 2 years of diagnosis. So this tells us very clearly that we need to focus on prevention, because when we prevent the disease, we are likely going to improve survival and we will prevent early mortality, years of loss of life lost to premature mortality from cervical cancer will be reduced, and there are economic benefits for that. So this evidence further emphasizes for us to invest in prevention of cervical cancer. Now, so what are the evidence-based strategies for prevention of cervical cancer? In 2018, many of us here have seen the launching of the elimination of cervical cancer as a public health program. And this is what the Director General said. One woman dies of cervical cancer every 2 minutes. Each one is a tragedy, and we can prevent it. Again, if you look at the opening slide, where we talk about, we know the strategies, we know what to do to prevent this. Why are we still allowing women to die of this disease all the time? So that was the basis for the Director General of WHO to launch this initiative. And a lot of countries have really keyed into this, and they are making progress. But we are yet to see that. I mean, we are making progress too in Nigeria, but we will need to evaluate ourselves to see where we are. So what does it mean to eliminate cervical cancer? And this is the definition. You know, it defines elimination as reducing the number of cervical cancer cases in each country to 4 cases per 100,000 women or lower. And when this threshold is achieved, it is considered that cervical cancer has been eliminated as a public health problem. How many countries have achieved it? As we speak today, no country has achieved elimination yet. Though I saw a particular write-up, which we will see, probably 2 countries, Switzerland and Malta, are the countries that are getting ready to achieving elimination. I presented this yesterday, that through cost-effective evidence-based interventions, including human papillomavirus, vaccination of girls, screening and treatment of precancerous lesions, and improving access to diagnosis and treatment of invasive cancer, we can eliminate or prevent cervical cancer as a public health problem and make it a disease of the past. So what are these evidence-based strategies?
I just want to remove it so that it doesn't.
Mommy, will it cause any problems in the class?
So if we invest in vaccinating girls, and based on the WHO targets for 2030 that we talked about yesterday, if we vaccinate 90% of young girls before they reach the age of 15, we will have stopped them from getting infected with the causative organism for cervical cancer. And this is primary prevention. It's something that we need to work on. Coming back to Nigeria, I mentioned at the beginning, we still do not have a national program for vaccinating young girls against human papilloma virus. The second thing is that those who have not been vaccinated, and even those who have been vaccinated, we still encourage the issue of screening for early detection and treatment of precancer, the cervical intraepithelial neoplasia lesions we talked about yesterday. So we can do that either by pap smear or by VIA or VLI or HPV DNA testing that we talked about. So early detection and treatment of precancer. And this is what we have said that we need to do and achieve up to 70% in this area. And then treatment should be up to 90% of those that we detect with precancer. The other strategy is early diagnosis and effective treatment of invasive cancer. In JAWS and a lot of other centers, Previously, people just make diagnosis through examination under anesthesia, Figo staging, and then we refer patients for chemoradiation. But we discovered that a lot of these patients were dying while waiting for chemoradiation. So it has been shown, evidently proven, that if you offer early tumor control, especially for early invasive cervical cancer stages, you can achieve almost a cure for this cancer. So these are all strategies that have been proven by evidence. And yesterday we talked about this. I don't want to belabor it again. All right. So what has been done globally? This is a special report, the European response to the World Health Organization call to eliminate cervical cancer as a public health problem. And this is what is reported here. When they look at where they were standing, looking at all the member countries, and then the age standardized mortality rates, age standardized incident rate. If you look at it over here, the blue bar stands for the incidence as well as the gray bar stands for mortality. And if you look at it, all those countries from Latvia here down to even Switzerland, they have not reached the threshold mark for elimination. This is where the threshold is. That is 4 cases per 100,000 women years. So the only country that is very close to that is Switzerland and Malta. But this is the situation report from Europe. And when they look at their vaccination coverage, you can see where it is, where they have the data. There is no country that has hit the 90% mark or target. But some of them, Portugal is on its way, UK is on its way, 81. And if you go around, Malta, 81. So they are making progress. Now, if you look at it, based on what the European Union evaluation, they came up with specific actions. Action on HPV vaccination, they have talked about it. Action on screening and early diagnosis. Action on HPV vaccination and screening, and then action on treatment. So these are all action points, but it's based on a desk review of the situation in Europe, and they are now putting everything, on the line to ensure that by 2030 they are able to reach that threshold mark that they are currently lacking behind. What of the North America? And they have done a lot. And if you look at the publication, the Lancet Public Health 2020, they have looked at the projected time to elimination of cervical cancer in the US. And I will just read this interpretation. This is the conclusion of the matter here, that the US is on track to eliminate cervical cancer as a public health problem in the next 2 or 3 decades. The time to elimination could be expedited by 10 to 13 years by achieving higher screening coverage, which we can do. Targeting of underscreened and under-vaccinated women remains a key to achieving that. So screening high-risk population. And I want to just say here that even as a country, and MWAN also, we should, as we are planning our own outreaches, we need to focus on high-risk populations. Who are those people that are more at risk of developing this cancer? Those who have never screened. Of course, vaccination, we may not talk about it because majority of women in Nigeria right now, as we speak, have not been screened. So targeting the under-screened, high-risk population can lead to high yield in precancerous abnormalities, and it will make our outreaches very effective. But if you do an outreach and you are approaching population that is not really high at risk, it may take you, so much effort to get abnormalities and treatment. But this is something from a purely cost-benefit, cost-effectiveness standpoint. If you want to devolve your limited resources to give you maximum yield or impact, you need to think about the high-risk population of women that will benefit from it. And that's what the US look at. Now, there is this modeling too, that they focus on low income and lower middle income countries, including Nigeria. And they did a projection, a modeling of the impact of HPV vaccination and cervical screening on cervical cancer elimination. So they have looked at it that predictions were consistent across 3 models that they used. There were 3 model scenarios. And it suggests that high HPV vaccination coverage of girls can lead to cervical cancer elimination in most LMIC by the end of end of the century. And then screening with high uptake will expedite reductions and will be necessary for us to eliminate cervical cancer in areas with the highest burden. So this model is actually speaking in support of those strategies we talked about. Screening for precancer, early treatment of precancer. And if we do that, it will really help us in reducing the burden of cervical cancer in our country and even in our sub-region. So briefly, this is the life course approach to cervical cancer prevention. So between 9 years and 15 years, we've been told we need to vaccinate these young girls because there is high risk of HPV infection. That's around the age that a lot of young girls begin to have sexual intercourse. So HPV infection gets to its peak. So if we want to prevent this, then we need to focus on primary prevention with primary preventive vaccines of young girls between 9 to 14 years. Latest, by the time they are 15, 90% of them should have been vaccinated. Then when we get to the area of secondary prevention, we need to start screening, at least for women who are 30 years and above. And again, WHO second edition of the WHO screening guidelines support this, that we should initiate screening now at 30 years. Most of us, we've been talking about initiating screening at 21. At some point, it moved on to 25 years, but the evidence is showing us now that with limited resources, if we are going to invest in screening a woman just once in her lifetime, we should start at 30, or even do that first screen at 35 years. And if possible, we repeat it again at 45. And then at tertiary prevention, I've talked about the importance of surgery for early stage invasive cancer, the issue of radiotherapy. Radiotherapy is a big issue. There's a gap in Nigeria. For a very long time, I don't think we have more than 8 functional radiotherapy units in Nigeria. And most of the time, not many of them are functional. All right, the issue of chemotherapy, and then the aspect of palliative care. So as we focus on primary and secondary prevention, we also need to develop resources and facilities for surgery, radiotherapy, chemotherapy, and palliative care. So how are we doing in Nigeria with prevention and how to attain the WHO cervical cancer elimination targets? Some of us probably have talked about this, but this just tells us where we are. These are IAC data that shows the burden of cervical, the annual incidence of cervical cancer cases in Nigeria, where about 60% of them will die within the first year of diagnosis. And if you look at the screening coverage, it's about 8.7%. That's less than 10% of women who are in need are getting screened. And then HPV vaccination program, we do not have it. Most of the areas that are receiving HPV vaccination now are either in a private setting or some programs supported by NGOs or first ladies that we have in Nigeria that are supporting some of those. And when you come to screening, there is no cervical cancer, organized screening program, and then there are VIA pilot programs, which a lot of us are aware of. Professor Ugu and others who have been doing this can tell us more about it. But some of this other information we do not have. So what are the current challenges towards prevention in Nigeria? To summarize, one, lack of a national program on HPV vaccination. There's lack of organized screening program. As I mentioned, most of the programs are opportunistic in nature. The issue of late presentation of cases with poor facilities and resources for optimal treatment of invasive cervical cancer. I have said again, this is one of the points that, further emphasizes or call for the need for us to invest in prevention. And then the issue of lack of social support and financial protection for women and families with diagnosis of ICC. Those of us who are taking care of these women can think about it. We know we can share some of the frustrations we go through in managing these patients. I have had several instances where I will have to call members of my team to contribute. We will contribute money just to make a diagnosis and even support treatment. So most of these women, they are very poor. If you recommend treatment, surgery, they can't afford it. So lack of social support, lack of financial protection. And a lot of these women end up becoming bankrupt. The families will drain their resources and die of the disease. And this again tells us the need for us to invest in prevention of this cancer. So having said that, where do we go from here? Who will lead the way? Last time I talked about this and I say NMA, is it NMA that will lead the way? Is it the Society of Gynecology and Obstetrics of Nigeria? Is it GOSON? Is Ministry of Health? How are they going to coordinate? MWAN is making a lot of effort. How do we coordinate all these activities? If we are able to make our contributions individually, as a society, as a ministry, then at the end of the day, we'll make incremental benefits, incremental gains in getting to these global targets. So this is an effort from the Society of Obstetrics and Gynecology of Nigeria, and they publish a clinical practice guidelines, and it just summarizes, or they agree with the fact that girls aged 9 to 15 years should be vaccinated, and then the issue of secondary prevention through screening with cytology, visual inspection, HPV DNA testing, and all the other methods of detection of precancer that we talked about. This is just to tell us the percentage of countries with a national cervical cancer screening program. And if you see, in income countries, over 80%. Upper middle income, about 30%. When you come to lower middle income, it is around 50%. And the low income countries is less than 40%. In Nigeria, most of the screening coverage that we have for the opportunistic services is reaching just about 9% of women who are at risk of developing this cancer. I want to end this talk by briefly looking at the economic benefits of advocating for prevention. Sometimes when we don't look at the economic benefits, we just look at, well, family A, B, C, they are the ones that have a condition. Me, X, Y, Z, I don't have it. So we don't look at the societal burden, the societal loss in the patients that are having these cancers and they are dying. So, but when we do economic analysis, it gives us a better understanding. And looking at a model that look at the cost effectiveness of human papillomavirus vaccination in 179 countries from the prime model. If you look at it here, the regions are at high risk of cervical cancer. They have the most benefit of reducing, the number of cases with cancer and also reducing the proportion of women with deaths. If you come to high-income countries like US, you can see the benefit is 5.1% in terms of incidence, as well as 3.8% in terms of prevention of maternal of deaths. But when you look at low middle income countries, look at the proportion here, 46.8% benefit, as well as 47.5% benefit. Again, telling us that if we invest in vaccinating young girls in low income countries where we have the highest burden of this disease, then we'll have the highest economic impact. So the case for investment, and this is summarized in the WHO document, that by investing to meet this 90-70-90 targets, an estimated 200 million women will remain productive members of the society, adding an estimated $28 billion to the world's economy through 2050. Now, if you look at this, one thing that people don't do when you do economic analysis, died of cervical cancer at the age of 50. About 20 years of her productive life, you have cut it away. And when you look at the economic loss associated with that premature mortality, you will now understand that this estimate of $28,000 billion is not an overestimation. It is real. And economists look at years of life lost, all right, potential life years lost, premature mortality. And when you put all those economic indices, you will find out that we will save a lot if we prevent this disease now. We can save a lot of money in the future to treat the few number of women that will develop invasive cancer. And this is a summary of the economic and social benefits. If you look at it, it will boost the GDP because more women will remain productive. It will increase the workforce participation. It will reduce hospitalization. There will be more money for health. That is, those who will require treatment for invasive cancer, we have saved money from prevention. So the few that will have the need for treatment, we can now use that money to treat those people. So more money for health. People become healthier, increase life expectancy, increase earning capacity because they are productive, and then it protects potential risks of NCDs. For example, just of this, I have a young woman who is just 25 years, though HIV positive, but she has invasive cervical cancer. And we had to struggle to do all we could to do surgery for her because we were able to make the diagnosis at relatively early age. And then she will now do adjuvant chemoradiation now as a means of improving her longevity. But supposing that young girl does not get treatment and she dies at 35 or maybe 37, you can see we have cut down close to 30 years of productivity in her life. So as we talk about prevention, we need to the economic aspect of it, and we should use this information to do advocacy to our policymakers and government. So I want to end by saying that we know that cervical cancer is preventable. We know the interventions needed for its prevention. These interventions are not just effective, they are cost-effective and can contribute to social and economic development of any society. Our policymakers should analyze these benefits and work towards the attainment of these targets, goals, and prevention. I want to say thank you, and I'm happy to take comments. Thank you very much.
Thank you very much, Prof. Musa, for such an inspiring presentation, and your charge to the policymakers is well taken. I believe we have some of them here, and these policymakers, many of them are doctors. And so the question is, how do we leverage on our resources or our leadership positions across several levels? We have doctors all over the place. They are leaders at facility level. They are leaders in health institutions and establishments, ministries, departments, and agencies. There must be a way to leverage these positions to be able to commit to this investment that Prof has spoken about. So I believe we will be getting more of that as we go on. And we have a hand raised up for a question. Dr. Mary Agoyi, please, you can unmute and give us your question.
Good evening, Ma. Good evening, sir. Thank you, Prof, for the really beautiful presentation. I would want to ask, okay, so in the prevention, you primarily told us that the primary prevention is to vaccinate under 15 female children. But in my time in family medicine, a number of times, like the 2 cases I saw, most times the women or girls, okay, they are not 15 anymore, maybe they're like in their 20s, but they usually come maybe when they find out that their partners have genital warts. And you know, at least from medical school, from what we know, genital warts are usually being caused by most of those viruses. So for those people that they only come maybe for vaccination or anything when they find out that their partners have genital warts, does it have anything to do with the progression of the possibility of cervical cancer in them? And the second thing I want to say is, okay, while we say the government and associations, I think NGOs too, some NGOs to have some roles to play, because some of them are invested in maternal and child health. And I think if everybody, not just associations that have names, not just the government, even at the level of churches, mosque, if everybody kind of work towards it, it's something we can get to our goal faster. Thank you.
Thank you. Prof, would you like to respond?
All right, thank you very much. Thank you for your kind comments. And your comments are well taken. As it has been said, most of the policymakers are probably part of this meeting. And those of us in the women's health space, we need to really up our games in terms of advocacy and seeing what we can do. And one of the tools for advocacy I've seen is generating the right data for us to use to do effective advocacy. And if we continue to do that, approach NGOs, other well-meaning, goodwill Nigerians, they can invest into some of these strategies that we talked about. So your comments are well noted. And I'm also aware that a lot of faith-based organizations, churches are also doing a lot of awareness creation as their own contribution towards this. So your question on HPV vaccination when someone notices that a partner has warts, all right, we know that the vaginal warts is usually caused by the type 6 and 11. They are low risk HPV types. But again, if someone has vaginal warts, it's also a high risk factor for future development of cervical cancer because the high risk may probably be part of it. So once you have a partner with vaginal warts or penile warts, it shows that you are actually having a high risk exposure. Now, at that point, doing HPV vaccination may not be that effective unless because you've already been exposed. So the type of vaccine that will take care of that is therapeutic vaccines, which people are still doing research to see how they can get a therapeutic vaccine that can flush out the virus if it has already infected the vaginal and cervical tissues. But right now we do not have. So if you have such type of patient, you should invest in educating them, in avoiding those high-risk lifestyle, and also to avail themselves for screening, because we will not be able to say whether those pre-malignant lesions have already started or not. But we all know, again, that HPV, symptomatic HPV infection is already a risk factor. So DNA testing, and if they are negative, maybe
Please mute everybody. Oh.
I would mobilize.
So I don't know if I was able to answer your question satisfactorily.
I think you've done justice to that. Yes.
Thank you
Thank
very
you so
much.
much.
Thank you.
So without much further ado, we are going to go to the next presentation. Professor Uzrama Ago, are you in the house? I'm trying to.
Yes, I'm here.
Okay,
I'm
thank
here.
you so much. All right, let me make you a co-host so that you share your screen. You're going to give us a presentation. This is a presentation on visual inspection with acetic acid. That's the screening procedure many of us have been using to conduct outreaches for early detection of cervical cancer and pre-malignant lesions. So, Professor Agui, you have the floor.
All right. Good evening again, everyone. It's nice to be here again this evening. So I will be taking the visual inspection with acetic acid. And so I will be my title will be testing and reporting the results. I've been asked this question all over and over again. Who should screen? I've seen microbiologists asking me, can I train them? Of course, we're already used to nurses doing this. Can choose be part of that and all that? Yeah, most people will be able to do this so long as you have the good knowledge of anatomy, good knowledge of physiology. We did something about this yesterday. Good knowledge of pathology of the cervix in relation to visual examination. no clinical features of benign conditions, have good clinical knowledge of inflammation of the cervix, and good clinical knowledge of precancerous lesions and invasive cancer of the cervix. So an engineer will not be able to do this, I'm sure. So I'm sure most of our CHUs can, our nurses, all of them should, all doctors should be able to do visual inspection with acetic acid. It's not left only for gynecologists. Yes, not only for gynecologists. Family physicians should be able to do this. Community physicians should be able to join us in fight against cervical cancer by acquiring this skill. Now, what do we need? First of all, we need examination table with knee crutches or leg rests or stirrups. Even if you don't have that, the woman can just, stay in the dorsal position. And the most important thing is you should be able to be comfortable enough to have, your head level, at the position that could make you see the cervix very well. You should have a very good light source. If you know you're going to have problem with light source, make sure the couch is positioned in such a way that natural light can also, give you a good light source. Sterile bivalve speculum is what we use to expose the cervix. Could be corkscrews, could be the Graves or the Collins. And then you need a pair of gloves. You can double. But most of the time, we teach people how to do all this examination without necessarily touching the patient too often. So a pair of gloves should be okay. Then we need cotton swabs, cotton tip buds. We need gauze as well. Then you need the ring faucet for, handling the cotton. But there's this small, easy, and beautiful way you can actually do a lot of screening without having need for faucet. You can do use a broomstick, the coconut broomstick, and then sterilize it, and then use this cotton ball, form a cotton ball with it, and then beautiful, sterilize them, and you can use that and throw them away after use. You don't need to sterilize new faucets. I call that the India stick. I learned it when I did the training in India. And I think a lot of us have started doing that. All the centers I've gone for training. All the centers that have invited me for training, I usually would teach them how to do that. We need 5% freshly prepared acetic acid or vinegar. Yeah, the word is freshly prepared because the people that thought this VIA from the very beginning will tell you that with time, oxygen will react with this prepared acetic acid, and then you will have false results, okay? But then if you are able to prepare this acetic acid and you have a very good cap, you can use your syringe, but cap it when you're done. You can actually use it for the next few days without discarding it. But please, for you to be sure, discard after 24 hours. You need a steel plastic container with 0.5 chlorine solution in which to immerse the gloves. A plastic bucket or container with 0.5 chlorine solution to decontaminate instruments, and a plastic bucket with a polythene bag to dispose of contaminated swabs and other waste items. Okay, so once you get the woman to know what you're about to do, you should explain very well the procedure and then obtain a written informed consent. A lot of us don't do this, but it's very important you do that. Obtain a written informed consent. A woman came to a woman one day with the husband, and I tell you, the husband was like, why did she call for screening? And she said she was told it was by force, because she presented with something in the hospital. And so, but really, she actually came for the screening and nobody forced her. But she came to prove that it was by force. Thank God for written informed consent that protected the Well Woman Center. She had a positive lesion and needed to be treated anyway, and the man was devastated. So why would she scream and then bring the burden for him? Let me not continue the story how we sorted that out, but we treated her eventually. Get her to relax, okay? After taking the obstetric and gynecological history. But I know that most of the time when we're in the field, we find it difficult to get this done. But it's something that you have to. Please, you have to get enough people to do the filling of the forms and then get everything about the woman before you proceed. The woman is invited to lie down in a modified lithotomy position on a couch with leg rest or knee crutches, like I said before, stirrups. And remember, you can just do that in this position if it's comfortable for you and the woman. And if you're able to get a good exposure, some very heavy ones may make it difficult for you. After proper positioning of the woman, observe if there is any vaginal discharge. All right, observe the external genitalia and perineal region for any signs of excoriations, edema, vesicles, papules, sores, ulceration, and warts. And look for any swelling in the inguinal femoral region. Some of these things will help you know what to expect when you start your examination or when you start inserting your post speculum. Sometimes some of the things you see may require you to do a digital examination before you continue. Afterwards, gently introduce a sterile vaginal speculum, which has been immersed in warm water, and open the blades of the speculum to view the cervix. Now, if you don't have warm water, I tell you most of the time you will have warm water around you to do that. You can tell the woman you feel some coldness, okay? Just let her know what so that she don't get scared because of now, but for the plastic ones we use, we usually don't have this problem. We usually have this cold sensation when you use the metal ones. So adjust the light source so that there is adequate light in the vagina and on the cervix. As the speculum is gently opened and the lips are fixed, the cervix comes into view. If you're not able to do that, you can just simply tell the woman, cough a little bit, ma'am, and then the cervix will just come into view, if the cervix is there. Now observe the size and shape of the cervix and even the position. I have people with infertility that have come for screening before, and I simply told them to change the position of when having sex and after sex. A woman of 4 years of fertility became pregnant. So sometimes screening may help you, manage your patient that outside cancer stuff. Identify the external os, the columnar epithelium, which is usually white in color, the squamous epithelium, which is pink, and the squamocolumnar junction. You have to identify this. If you are not able to get the squamocolumnar junction, or maybe you see half of it, also you may do some manipulation so that you can see it. It's very important to see them completely. Proceed to identify the transformation zone. We talked about it yesterday. The upper limit of which is formed by the squamocolumnar junction. And remember that cervical neoplasia occur in the transformation zone nearest to the squamocolumnar junction. Look for ectropion. Sometimes when you just expose the cervix, you just see it staring at you. And some people have, if you don't know what to say in the cervix, they'll think it's cervical cancer and all that. You should be able to know ectropion when you see one. Look for cervical polyp. Note the Nabotian cysts when you see them. Huge laceration of the cervical lips, leukoplakia, condylomata, and other signs of cervicitis. Document these things. Okay. When you see signs of cervicitis, you obviously know what to expect when you do your test and how to read them. Otherwise, sometimes you may just, if you think there's copious infection, you just leave the screening so I don't confuse yourself. I usually screen everyone that comes to me. All right. But when you're starting to do this screening thing, you avoid things that will confuse you. Sometimes when you give the wrong diagnosis or your suspected diagnosis and eventually turns out to be something else, patients usually are not happy. They will not come to see you again. All right. You may know that in postmenopausal women, the cervix appears pale and brittle due to thinning and atrophy of the squamous epithelium. Assess the characteristics of discharge in terms of quantity, the color, the odor, and the thickness. These days I will wear double face marks, may not pick these things. Okay. The thread-like thin mucinous discharge from the external os indicates ovulation. We all know that. Okay. Now, if heavy blood flow through the external os is observed in women during menstruation, they may be subjected to VIA after 5 to 15 days. What I will do personally is to plug that cervix about and then do what I have to do, but make sure I see the squamous junctions all around. But when it's heavy, it's really difficult for you because the blood will keep coming. And when you do your Lugos, of course, you see non-uptake place. If you're not careful, you think it's positive. So just avoid heavy menstruation. All right. Some of these women, when they come during screening programs, they won't tell you they're menstruating because they just want to screen like their mates, or like others, because they know that your screening program may end in 2 days' time and menstruation may end 5 days later. So, but when you observe that, even if they don't tell you, you now tell them they should come back later if you have the if you still have that program running. In ectropium, the cervix has a large area of red appearance around the external os and the squamous junction far away from the os. I'm going to show you some of the pictures when we get to that. And look at this picture. This is a huge Nabotian cyst. The initial time you should train doctors on this. This is one of the ones they will always diagnose as invasive cancer. We should be able to know be able to identify Nabotian cysts, and most of the time they are very huge. And one beautiful thing about this, when you stain, you won't see a still white patch, and when you use Lugos, it will just be mahogany black. It's a beautiful assurance. All right. But if you're not sure, please go further to do biopsy. Okay. A cervical polyp appears as a smooth mass protruding from the cervical canal beyond the external os, which may appear dark red or pink white. Sometimes a necrotic polyp resembles a cervical cancer. Honestly, I had one, once, and it was so bad. If I referred the person to Enugu, eventually the doctor got back to me that thing was a huge cervix, was so embarrassing. So I just I examined thoroughly before I sent them away. Okay. Huge lacerations appear as tears on the lips of the cervix, with the external os opening, looking irregular. Leukoplakia appears as a smooth surfaced white area on the cervix that cannot be removed or scraped off. And like I said before, even by viewing the cervix, you see it. And then when you do your test, it will still give you as the whitening. And but when you have dense whitening of that same area, additional reaction to what you see before is good for you to biopsy that lesion. Don't let it go. Cervical condylomata appears as raised gray-white areas within or outside the transformation zone in the squamous epithelium and may be accompanied by similar lesions in the vaginal and vulva. Look for small blisters containing fluid or multiple small ulcers on the cervix. Extensive erosive red areas may be present on the cervix, extending to the vagina in instances of severe cervical infection and inflammation. So if you're not if you're novice in this thing, you quickly say, there is easily bruisability, you know, and all that, and start making us stop diagnosis. Okay. So when you have severe infection, just that cause will traumatize the cervix easily and may confuse you. So you need to know this. A very early invasive cancer may present as a rough, reddish, granular area that may bleed untouched. Okay, have to know this. More advanced invasive cancers may present as a large esophageal growth with an proliferative bulging mass with polypoid or papillary crescences arising from the cervix, or as a predominantly ulcerating growth, replacing most of the cervix. I did my slide in such a way that when you pick this slide anytime and go through them, you still educate yourself again on visual inspection with acetic acid and reporting. Now, in both of these types, bleeding untouched and necrosis are predominantly clinical features. Foul smelling discharge is also common due to superadded infection. Occasionally, invasive cancer can present as an infiltrating lesion with a grossly enlarged irregular cervix. The secretions may be gently wiped. Wiped. The swabs after use should be disposed of in the waste bucket. Now, the coding white discharge associated with candidiasis, it's particularly sticky, and if particular care is not taken to remove it properly, it may mimic an acetowhite lesion, those leading to a false positive result. And note also the place you scraped it off from also may also look reddish and inflamed, and may also give you acetal whitening that will confuse you. But usually it appears and disappears very, very fast. And of course, nowhere defined like the acetal white part that we're going to go through very soon. After removing the swab, carefully look at the cervix to see whether any white lesions appear, particularly in the transformation zone, close to the squamous-columnar junction. I repeat, close to the squamous-columnar junction. I call it above the squamous-columnar junction, or dense, non-removable acetal white areas in the columnar epithelium. So you see, when you stain and you see white, try to clean again. Are you with me? That we also, most of the time we have
yes, we are with you.
During screening programs, when I teach healthcare providers there, they will stand and say, still exposed. I say clean that thing, and they will just sit a mucus. So sometimes when you have these experiences, clean again, and then of course if it is a real acetal white patch to remain there staring at you. The results 1 minute after application of acid should be reported. So you wait for 1 minute. We're trained to wait for 3 minutes, but I tell you, if you go somewhere else and not looking at that service, it may appear and disappear, and then you'll not be able to assess that. But then 1 minute is beautiful, because sometimes if you're too much, if you do observe less than that, you may not get the lesion to just appear later, and then So give 1 minute after that, so that we have a uniform thing. Note how rapidly the acetal white lesion appears and then disappears. Very importantly. Okay. If you stain and you have to wait that 1 minute for you to see it, okay, it's not likely to be as bad as if you just stain and within seconds you are seeing the appearance, and then it's just there staring at you for a long time before disappearing. All right. Well, this one that you wait for it to appear and then, of course, disappears. I think you may just miss it. Usually, not bad ones, low grade, usually low grade. Carefully observe the intensity of the white color of the acetal white lesion. If it is shiny white, cloudy white, pale white or dull white. I try to get different, pictures that will describe this. I discovered that by the time you snap, and the whole picture will change and they all look alike always. But with experience, you know what we're talking about. The borders and demarcation of the white lesion. Should observe the borders and demarcations of the white lesion. Distinctly clear and sharp or indistinct diffuse margins, raised or flat margins, regular or irregular margins. Just observe all the shape. Whether the lesions are uniformly white in color or the color intensity varies across the lesion. It's very important you know that, because sometimes when you do a biopsy, when you send a white lesion in cervix and you do a biopsy, you may come out with CIN1 when you have actually 2 and 3 somewhere. So you need to observe when you have white lesion, look at it again very well and see if you have, places where it is less tense than the other. Okay, so that you can pick the place with the, highest intensity. And you can even actually pick all of them, like up to 3 or 4 places, and then put that in your, and fix and send for histology. Okay. And also observe either areas of erosion within the lesion. Okay. Location of the lesion. Check if it is near or far away from the transformation zone. So if it is too far, we call it satellite lesion. We're not as worried as if it is right there within the transformation zone and aborting the squamous-columnar junction. You have to check whether it's aborting the squamous-columnar junction. Does it extend into the endocervical canal? So the endocervical forceps is a very good equipment for you to have. That will help you assess the canal when you see white lesion, especially when you are planning to do see and treat, so that you don't leave the tail of any of this lesion inside the canal, and then give rise to cervical cancer eventually. And like somebody asked yesterday, like our president asked yesterday. So you have to look at it. Does it occupy the entire or part of the transformation zone? You check. Does it involve the entire cervix, which usually indicates early preclinical invasive cancer? So as it's moving, it's just be going round. Once it completes the circle, the next thing is to move in. So you observe that. And when you're describing, then you describe all this. Look at the size, the extent of dimensions, and number of the lesions. Right. If in doubt, it is safe to repeat the test a few times, taking care not to induce bleeding. Right? Women with suspected invasive cancer should be referred for further investigation and treatment. So, to conclude your examination, you withdraw the spectrum gently and inspect the walls as you are withdrawing them for condyloma and other white lesions. What you do is, if you need to, spray the white, the acetic acid, go ahead and do that. As you are withdrawing, just look at the wall. Now, before removing the salt gloves, immerse your hand briefly in a container filled with 0.5% chlorine solution, and decontaminate the used glove by soaking in the 0.5% chlorine in a plastic bucket for 10 minutes, and you discard. The spectrum and other instruments used for VI should be immersed in 0.5% chlorine solution for 10 minutes. The contamination before cleaning with detergent and water. Now, the cleaned instruments may be reused after high-level disinfection by immersing them in boiling water for 20 minutes or by sterilizing the instruments using an autoclave. That is, we're using metallic instruments. Most of the time now we use disposable specular. You don't need to do any other thing or to discard every single thing you've used for examination. Yes, it's very possible. Your glove, the sticks, the swab sticks, the just discard everything and that's it. Now, documentation of findings and advising the woman. Carefully document the outcome of testing in a reporting form. Explain the outcome of the test to the woman. Don't just say positive, negative. Somebody said yesterday, you just test the first positive, and remember the advert was come and screen for cancer, and you say positive, that means she's got cancer already. So this woman must be need to understand that there are other things that can also give positive results, and that you need to do further tests, to confirm the stage of the pre-cancer lesion. If the test is negative, the woman is reassured and she may be advised to repeat testing after 5 years, 2 to 5 years. If the test is positive, she should be referred for further investigations such as colposcopy and biopsy, as well as treatment for any confirmed lesions. I try to remain, keep to VIA. Most of the time, I don't do VIA alone. I do Lugos origin. I'm sure somebody will take that lecture. And if not, please, it's very advisable for you to also use Lugos to, together with VIA, increase your sensitivity or specificity, as the case may be. If invasive cancer is suspected, she should be referred to a cancer diagnosis to a cancer center, to a diagnosis and treatment facility, if you have any that is close to you, or you send to anywhere in the world. Some people can afford that. So how do we report? VIA screening is reported as negative in the case of the following observations. No acetoid lesions are observed. I'll go through the figures now. Look at this cervix. Look at this cervix. I don't know if you have seen my ponytail. That is this columnar junction here. Okay, just observe that. Columnar junction. Okay, if you see any Nabotian, whatever crypt, anywhere around, that will help you define your transformation zone. You can see, just note these advancing edges of the squamous metaplasia, okay, in the anterior lip and even in posterior lip as well of the cervix. It is negative when you see polyp. Polyp. Negative when you see Nabotian cysts, like this one. Like pimples, just appear like pimples in the cervix. I see them, all right? When you do Lugos, everything will be black, right? No acetoid white patch anywhere, okay? So it's negative VIA. When you see dot-like areas present in the endocervix, which are due to grape-like columnar epithelium staining with acetic acid, sometimes you see when you have your ectropion, you see dot-like, acetoid whitening, there. It's not positive, please. Just tiny, tiny things like small buttons. I don't like things. They're that negative. This is an ectropion. Okay. All of this, they turning turning out or something of the endocervix. If you see some of these, sometimes you see a slight discoloration, white discoloration. Okay, when you do the acetic acid, but there's no well-defined anything, right? And it's not really a patch. Okay, crowd-like, cotton-like. That's another one here. Okay. Okay. You see something like that? Shiny pinkish, whitish, cloudy white, bluish, white, faint patchy, just faint, ill-defined. It's not positive VI. When you see positive VI, you will never miss that. Okay. So you can see this is -2. There's a satellite lesion somewhere here. It's not close to the squamous junction there. This person uses IUCD. Sometimes could traumatize the cervix so much that you have, streaks of metaplastics right there, fibrotic, stuff in there. Okay, because of trauma. Yeah, when you have mucus, sometimes when you stain, can you hear me? It's like my voice is going down. Can you hear me? Anybody?
Yes, very clear.
Yes, can hear you.
Yeah. So when you see, when you
you.
have the mucus,
We can hear you.
stain, yes, and you stain, I tell
Yes, we
you,
can hear you.
you would think it's positive, but it's not positive. Look at the mucus here. But I like this reaction on the mucus. Sometimes it helps you check if your lugos is good. I attended. I was a quality assurance, somebody for a screening program somewhere. We mistakenly using spirits to do this stuff, and they were not getting results, So, because of course I wasn't cross-checking all of them, but I got worried when they got up to 100 with apples. I said, no, we have to look. Okay, then I looked at some of that. I had to do the test myself. I found out that no, none of the mucus seemed to be having any discoloration. So I had to let them check this thing. I poured it, tested it the way I used to on the floor. Nothing, no reaction. Then I put sure that you're having acetic acid here. So let us get a real acetic acid. When we're able to get another acetic acid and consider it, they started having results. So I have to be real. Anything can happen in this country. Some of these acetic acid they sell to you, small bottles, avoid them. Everybody's crazy trying to make money. Okay, so one way to test to acetic acid is to look at the reaction to the mucus. All right, so when you see things like this, that's not what we're talking about. Some of this one you're seeing here are metaplastic, cells, and we told you for the immature one, they could give you that whitish discoloration. But because you see it as a patch, it just, flashes, how do you call it now? Flushes with the rest of the cervix without any prominent demarcation. That is an octropion here too. Octropion. That's it. And there's no white patch anywhere. So when you do all this, they're all negative. They're all negative. Sometimes you may see an angry looking cervix like this. I've seen about 3 of this, usually for people using IUCD. I don't know. Yes, IUCD. Maybe they have a lot of that thread traumatizes the cervix, likely. I have that. I sent for, for histology, and everything came out to be, a fibrotic change and all that. And after some time, after they removed the IUCD, the cervix healed. Looks so nice. So sometimes you have to be careful what you define. And you see some of this cloudy white, slightly, discolored, whitely discolored area, whitish. There's no demarcation. There's no real patch anywhere here. So that's you define as -2. So let us look at the positive situation. When you see a distinct, well-defined, dense, opaque, dull or oster-white areas with regular or irregular margins, close to or aborting, I keep saying this, close to or aborting the squamous junction in the transformation zone or close to the external os, if the squamous junction is not visible. You see, please don't misunderstand this statement, because for some of us, we don't throw any service away. We stay in all services, whether we see the columnar junction or not. And the advantage, we have disadvantage and advantage to this. The advantage is, look, if there's any lesion that have grown to involve other part of the cervix, you will see it, and it will allow you to do further examination. But if it is negative, you cannot say it's negative. You know, when you don't see anything, you can't, because you have not seen this columnar junction. All right? Okay, that's just what it is. If it is there, fine. But if it's not there, you tell the person, go ahead and do pap smear. Or if you manipulate that, you can't get this columnar junction. All right? So look at this picture. I don't know if you are seeing it very well from where you are. If you look closely at this picture, you will see a well-defined. I'm drawing that with my cursor. Can anybody see this? No.
Yes, I can see it.
Yes, when you see something like
we can
this,
see it.
yes, can see it going into the cervix, into the cervix. With these finger-like things, digitation, you know, margins, but you can see the air, you know, you can see there's a defined edge. It's not as if, you know, you cannot just separate the surrounding from, you can separate the surrounding from it. This is aceto-white, positive. You can see a bit more in the positive, in the posterior lip, aborting the squamous junction and extending into the cervical canal. Nice positive result. Look at this. These pictures are not so beautiful, but we'll keep looking at the pictures. Look at this part of the cervix. You can see the edge from this side. You can see this, it's well defined. Okay. You have some in this part of the lip. And if you look at this cervix very well, you find out that this is supposed to be, you know, an ectropion before this damage started happening, right? You can see visibly there. That's the positive result. I'm sure you see this very well. Can you see what I'm tracing? Can you see that?
Yes, ma'am.
That is positive results. Opaque aceto-white area. Are you seeing the difference between this white patch from what we, the other services that we showed you before?
Yeah.
Are you with me?
Yes.
And you can see that it's aborting what? The squamous junction.
Yes.
It's aborting the squamous junction. I keep repeating. When you see something like that, that's another aceto-white lesion here. Well-defined opaque aceto-white area with regular margins. See that? There's more map. Are you seeing that? That is positive VIC.
Yes.
So when you're going to take your biopsy, this is where you're going to take your biopsy from. More pictures. I wish somebody can actually use cursor on my screen, but obviously online is not possible. But can you see what I'm tracing now?
Yes,
yes, this is what we call. Yes, that is positive lesion. This is a positive aceto-white patch. VI positive. Report should be VI positive.
Sometimes it's described as raised edge or rolled edge. If
Most
I'm
of the time,
right.
you may not even see them like that. You just see the patch looking flat. But most of the time, sometimes also you can see it, you know, like with the edge, like you just said. You get my point. But if you keep waiting for that characteristic alone, you miss many of them. The white patch is just there. Okay. That's another one. Now, please don't confuse this. You see, this is slight reflection, please. Are you see what I'm touching? This is slight reflection.
Yes.
This is the white we are talking about here. This is the aceto-white patch.
Very clear.
This, when you see this, you
The difference is clear.
can you see that? Yes. So when you do this and something like this appears, try to clean and it's still there. You clean the mucus and it's still there. If it's a mucus, to just disappear. And then when you do that test again, the cervix will be looking beautiful. Okay. And
Where
sometimes
should
you
we
see
take
some.
biopsy from?
Yeah, you take the biopsy from here. Yes, you take the biopsy from the lesion, this white place. You see, anywhere here within that lesion, okay? So I'll take it to take these places, you know, like this place is bruisable. Probably it was traumatized during the test. Okay. All right.
Thank you, ma.
See another one. It looks small, right? And I'm butting the squamous junction. Don't look at this. This is not it, huh? This is light reflection. This is what we're talking about. If you look at this, you see generally, you know, astral whitening of the surface of the cervix, but there's no well-defined edge. But look at it. This is what we're looking at. Okay. Hey, this one is so easy, right? Can you see this? Somebody talked about rolled edge. Yeah, this looks like that type you're talking about. Are you seeing that? Okay, this is acetal white.
Yes.
Yeah. You know, what is giving this okay, we talked about it yesterday, of course, the coagulation of proteins, right? That blocks off the reflection of your stroma. And you can see it extending to the cervical canal. Okay. Who is touching the screen and giving mark? It happened to somebody's slide yesterday.
Yeah, they said the Zoom.
Okay, so okay. Positive. When you have strikingly dense astral area seen in the columnar epithelium also, this is the columnar epithelium, and there's a very dense white patch in it. Don't play with that. It could just be adenocarcinoma trying to, you know, cause a problem there. If it were to be in the class, I wouldn't even tell you the result. You just tell me by looking. Okay? This is the columnar epithelium and this. Who is drawing these lines on the slide?
Sometimes when there's someone who's hacked into a webinar, they sometimes get a bit mischievous.
Okay.
So I think the host might need to identify who is doing this.
Okay.
It's a distraction.
Okay, okay. Now the entire cervix becomes densely white after application of acetic acid. In this case, look at it. Sometimes the whole thing, you can't rule out invasive here. Everywhere is just taken up and you start seeing bruisable areas there. Sorry, this picture is not showing you exactly what I want you to see, but if you look at this, I think this is showing the whole of this cervix is white. Okay. Condyloma and leukoplakia occurs close to the squamous junction, turning intensely white after application of acetic acid. You can give that as positive so that that person can be evaluated. Okay. Now, the text outcome is called as invasive cancer when there is a clinically visible or proliferative growth on the cervix that turns densely white after application of acetic acid and bleeds on touch, like this. Okay. Rollout ages, most of the time you see that. Here's another one. Are you seeing that? That's another one. Positive invasive cancer. So you can imagine somebody going to do cryotherapy for this one. or lip. I mean, you only just fasten the death of the woman. No, when you see something like this, go you send to Cancer Center for Management, please. Don't touch. Are you seeing the pictures? See another one. Ulcerative proliferative growth with astral whitening and bleeding when you touch. Okay.
Yes.
So now the text providers are encouraged to correlate the results of their VI testing with those of colposcopy or histology. You keep getting better and better and better and better. Unless they can afford to. Hello? Unless they can afford.
Please put on the heater for me.
Hello?
No. No.
Okay, I thought somebody was talking to me. So,
no.
So always correlate with the histology, okay? That will get you, make you better and better. Imagine the other, after seeing that kind of traumatized cervix 3 times with histology, histology, indicating nothing malignant, and over time healing the cervix, it will make you not to be afraid when you see that kind of a cervix. Sometimes when you also when you see astral-white lesions and you take biopsy and you check, you cross-check what your diagnosis, it will make you get better and better. Right now, if I do VI, I can almost guess if it is CIN 1, 2, or 3, 80% of the time. So because I've done it over and over and over, and some can embarrass you. There's some that will come back and tell me it is negative. I'll tell them I refuse that histology result, that it cannot be negative. And when we try to repeat again, it will just confirm, that what I said. And that's the confidence about doing this over and over, So, sorry, I'm not saying that histology is bad, but, sometimes these things can happen. So when you do this over and over, your confidence will increase. Okay. And keep reviewing this with the people you are training, and it will make them get better and better. A benchmark to assess one's own skill is to estimate what proportion of women examined are scored as acetopositive, and what proportion of acetopositive women are ultimately diagnosed with CIN. When we started this business, 30% of the time we say positive. By the time the surgery comes, half of that will be, inflammatory, with no malignant, with no dysplastic cell anywhere. But with time, when we say positive, when you go for histology, we just come back with one CIN level or grade or the other. So it's beautiful. It's something that you just keep doing, and you just get better and better. Now, WHO, I picked this from the WHO document. Is a sufficiently skilled examiner. We categorize 8 to 15% of women examined as acetopositive. And imagine 20 to 30% of the acetal lesion identified on VI by the test provider harbors CIN of any grade. To me, this is slow. Just 20 to 30%. No. We want to get to when you do your test, 80% of the time you should be able to be we're able to really get CIN if you say that it's positive. But that will come with experience. That comes with experience. All right. I think I just want to show you this picture as the last one. This is somebody we 3 months ago, a few days, 3 months, 5 days, she came, had this test done. We got this white patch here, all right? And then we did the villi and came out positive. I hope somebody will take villi in this training. And then, if you can see this, the white place is same place as the non-uptake area. And we did a leap. We had to cut everything, just cut everything. Make sure we took this place, deeper than the rest. But homogeneously, we cut everything and then secured hemostasis. And 3 months later, she just came, and the cervix looking so beautiful, like a woman that I've not delivered. But she's a para 5 woman, but you can see she's looking like not a para, and that's the Lugos, 3 months later. So this is some of the kind of what will deceive you later on with time. When you see this service now, you now gaze that the woman have never done a vaginal delivery. No, if she has done a leap before, that would be deceptive. So see how beautiful it is. There's this saying that the bladder is forgiving. I think a cervix is one of the forgiving organs in the body as well. By the time you finish with cervix, you never know that anything, any trauma, anything happened to it. It's so forgiving, so beautiful. So this is what excites me, with the treatment of positive vials. So thank you very much for giving me the opportunity to go through this with you today. I'll take questions.
Thank you so much. Thank you. Oh,
Thank you.
So
God bless.
inspiring.
Thank you, ma.
Thank you so much, man.
Thank you very much, madam. We appreciate it.
Thank you, ma.
Very much.
Thank you.
Thank you. Thank
Thank
you.
you so much.
Okay, I have 2 people raising their hands.
So we have
everyone.
this up. Yes. So me, can you ask your question? Or is it mistake?
Hello, good evening, ma.
Good evening.
Thank you for the presentation. Please, my question is, what about the case of suspicious for cancer?
Yes, that is yes. Suspicion for cancer is the one I told you about, invasive.
Okay, because at times I do have this cases of contact bleeding, and at times might really be much.
Yeah, like I told you from the beginning, I told you that when you have inflammation in the cervix too, you can have that happening. You get? So you have to examine the cervix very well so that you don't dash a woman suspicion for cancer. The ones you describe as suspicion for cancer is this ones. Are you with me?
Yes.
Are you with me? These are the ones you write. Because you don't have histology yet, you cannot say you have cancer, madam. Are you with me? So you write suspicious for cancer, and then you do biopsy, examination under anesthesia, and then you stage it. You go and do histology. You take a part of the lesion, the abnormal and normal area, and then send for histology. So this is why you write suspicion for cancer. Are you with me?
Yeah, yes.
Yes. So you can't just look at a lesion in the cervix and dash. Like I told you, I gave you a small story. I saw this polyp, very ulcerated and everything, looking so angry, and I felt so bad for the young girl. I was wondering why a young girl like that will have that kind of lesion. Okay, but eventually I actually sent that to Enugu, and then I was told this polyp that was protruding and got traumatized and got infected and all that. So removed, and she's fine today. Okay, so in that case, if I say cancer, voila, so it's suspicion for cancer. And then, though I made a big mistake, the mistake I made was to send her away without testing first. I was supposed to take a biopsy, and then, but because she came to me from Enugu, I just sent her back to a good doctor at Enugu. instead of making her come up and down, to access care in my facility, I decided, okay, since you are coming from Enugu, I recommend this person to see you. I think it was Chibu I sent her to. And then, she was cared for. And then he got back to me that's just a fibroid a polyp. And so and when I see that kind of lesion, I don't get scared again. I just look at it very well. So these things happen. That was some time ago.
Thank
All
you.
right, so
Prof, somebody asked on the chat. Prof, somebody asked in the chat that are we safe for IUC in the service? Is there any way somebody the IUC advertising the service?
I can't hear you well.
Somebody asked in the chat,
okay,
that are we safe if IUCD is the service? What can be done
are we
to
safe
avoid
if
the
IUCD is damaging the cervix like that? Is that the question?
Yes.
No.
That's
like I told
question.
you. Yeah, I told you that when I checked with histology, it came out, without any malignant cell. All right. So I felt it was a trauma from the IUCD trade, but I've not done any study
what can we do? What can we do to avoid the IUCD threat traumatizing the cervix?
I honestly don't know. Because the trade has to be there for you, because you have to be checking to be sure that your ICD is still intact, after every menses. So we can't say, okay, let them remove the thread or something like that. So I have no idea whatsoever how to prevent an IUCD thread from damaging the cervix. But most other ones also have IUCD that didn't damage the cervix. So it's not as if it is a common occurrence. But I've seen 3 with IUCD, doing that, and I think I'll keep that records, and if I find out that everyone, maybe in the family planning clinic, we'll get them back. All those people with IUC, we'll check them. Yes, we'll look further. Yes, if we find out that it's damaging, we create awareness about that. But for now, those 3 cases, there was no malignant cells, so I don't know. I can't prove that it's causing cancer.
Dr. Debbie has been raising her hand and she has posted her question in the chat. Yes. Is this the same for women that are not sick? So
I can't hear you well.
Or any other issue.
I can't hear you well.
There's a question in the chat. Check the chat. There is a chat. Read it.
Now.
Can I ask the question?
Yes, ask it.
Yes.
Okay, I wanted to ask, I don't know if I came late. Is the procedure the same for women that are not sexually active? How do we screen them without causing any injury?
Don't sexually.
No, if they're not sexually active, you don't squeeze. Those that are not sexually active.
Don't do anything.
Oh, so we can give them the vaccine without.
Yes, you can give them vaccine. Yes, you can give them vaccine. Remember, you can't put cortical speculum into a virgin vagina now. You tear the thing.
Yes.
And it's not fair to go and tear this precious thing.
All right, Zainab.
Sexually active is relative. Oh.
Question.
Sexually active is relative. Oh. Hey.
Yeah, it's true that there's this case of anal sex that protected the vagina. The vagina, right? Hello.
Okay, can we have Zainab, give you.
Yes, ma'am. Yes, ma'am. Thank you very much, Prof, for the very insightful discussion. I actually want to comment on the issue of IUCD damaging the cervix. I had actually seen one in our family planning clinic, and the cervix was really looking angry and all that. And then, yes, we sent her for histology and it came out fine. It was negative. You know, we were surprised because we couldn't believe it. In fact, we had to resend her, and it also came out as negative.
Yes.
So I think, like you said, it's something that we should really look into. Thank you, ma'am.
Please. I think so.
Okay.
I
So
think
it's
based on individual's body reaction.
Okay, we want to thank Professor Agu for that you're in our memories for a long time. Okay. So
Thank
we're
you,
going
ma'am.
to the last learner at 10 o'clock. We want to remind those learners that they can break and for their class. And right now we have the last lecture for today. Outpatient management of pre-cancerous lesions. So I'm going to make Dr. Professor Kaya the host, co-host, so that he can share his life for last presentation for today. Thank all for participating so massively. The passion for elimination of cancer is infectious. Cancer of the cervix is infectious, and Prof, please, can you raise your hand or signify that I can identify you and make you a host? And you
Can you see me? Hello?
Yes, we can see you.
Yes, we can see you.
Yeah, but you have disabled that function.
We are seeing more of your glasses than you.
We can see you with your hands, but it's frozen.
Prof, we're seeing you.
Okay, can you please enable screen sharing? It's stated that you disabled it.
If you make a co-host.
I still can't share my screen. The function is still disabled. Hello? Can you enable screen sharing? Hello? You are here to enable screen sharing.
It's like you have to be a co-host for you to be able to share.
Yes, you make me the co-host. I can't make myself the co-host.
I think Madam President, is she on?
Mute yourself first and let your children, let your mom wife carry your children now.
All this incursion, we don't want to make we hear what. Please mute everybody.
Yeah, please, good evening, everyone.
Good evening, sir.
Yeah, good evening. We want to thank the organizers.
Good evening.
Yeah, we want to thank the organizers for giving me this opportunity to address this august body. The title of my topic today is Outpatient Management of Cervical Pre-Malignant Lesions. Historically, cervical pre-malignant lesions have been managed with hysterectomy and cone biopsy, which results in loss of reproductive functions and adverse obstetrics outcome. The main problem with this approach is that women are scared of coming for screening because they know that once they are screened positive, they lose their uterus, or those that don't lose their uterus have the risk of premature delivery. Unfortunately, this method of treatment still occur in this part of the country due to lack of equipment mainly. Now, let's go a little bit historically.
Sorry, Prof. Some of us can barely hear you.
Oh,
Sorry,
you can't
Prof.
hear? Okay.
Yes,
Cervical
please.
cancer is a highly preventable disease. This is so because the precocious lesions can be identified. Can you hear me?
Yes, we can now. Thanks.
Yes, we can.
Now, cervical cancer arises via a series of 4 necessary steps. These steps can be reproducibly distinguished from each other. They are HPV transmission occur first, then there is persistence of the virus, then progression of a clone of infected cells to free cancer. Up to this level, the process is reversible. That is, viral clearance can still occur. After this, then you have invasion, when the pre-malignant lesions invade the basement membrane. At that point, it's a point of no return. Now, cervical cancer, in the treatment of cervical cancer, we need to understand a little bit about the physiology, anatomy and physiology of the cervical transformation zone. Because cervical cancer usually arises from a ring of mucosa called the cervical transformation zone. This is defined as the tissue between the old and the new squamous-columnar junction that has undergone squamous metaplasia. Now, treatment is an important component of cervical cancer control because if you screen and you don't treat, you are not going to reduce the incidence and mortality from cervical cancer. You only cause unnecessary anxiety in women. Effective management of cervical pre-malignant lesions depends on destruction of that transformation zone. That is the transformation zone from where the pre-malignant lesion arises. I have defined what TZ is, that is between the old and the new squamous-columnar junction. This is very important for screening and for management. How do we identify the TZ? I will show in the next slide, I will show you there are actually 3 types of TZ. We have the type 1, type 2, and type 3. This is what the transformation zone looks like. This is the cervix. When you are looking at it end on with a speculum. Can you see my cursor? Hello?
Hello,
Yes,
it's
sir.
not visible.
Can you see the cursor?
Okay.
Yes.
Okay,
Is this
yes,
slide
yes,
clear?
yes.
Now, this inner portion that is reddish, that is columnar epithelium. The outer boundary is the new squamous-columnar junction. Now, outside, away from this junction, there's a region of cervix that appears pale, not as red as this place. Usually, we identify it with the presence of 1 or 2 Nabutian cysts. If we draw an imaginary line around it, that gives us where the old squamous-columnar junction used to be. The tissue between the old and the new squamous-columnar junction is called the transformation zone. Now, how does the transformation zone arises? As we are all aware, a girl child about 5 years without earring, if she barbs her hair, you can hardly tell her if she's a boy or a girl. But with the advent of puberty, there is exogenous secretion from the ovaries due to the effect from the higher centers. This estrogen leads to the appearance of secondary sexual characteristics. Is that correct? Hello?
Hello, it's correct, sir.
Yes,
Very
sir.
good. Also, the genital structures are also responsive to what? Estrogen. Now, the cervix, the vagina becomes what? Colonized by what? Glycogen will be laid down in the vagina, which will be acted upon by bacillus to lead to production of lactic acid. Now, the increased estrogen production also inverts the columnar epithelium onto the what? Onto the cervix. This comes into contact with the lactic acid produced there. A process called squamous metaplasia occurs. The old squamocolumnar junction moves out, and there's a new squamocolumnar junction. The space between the old columnar junction is the transformation zone. Now, identifying is very important in the outpatient management.
Please mute everybody now.
Correct identification of the transformation zone is very important both in screening and in the management of cervical pre-malignant lesions. In the last slide, I said effective management depends on the destruction of the what? Cervical transformation zone. Now, I mean, that zone needs to be what? To be destroyed. Either we destroy it here or we cut it off. Is that explanation clear? Thank you. Now, several studies have shown that.
Yes, sir.
Studies have shown that outpatient management of cervical malignant lesions is effective, is cheaper, safe, no need for hospital admission, and there's no need for what? Being exposed to the threat of anesthesia. When we're talking about outpatient management of cervical cancer, there are two approaches to this. There is what we call see and treat. In see and treat, treatment is offered without any histological confirmation of disease. And the aim of this is to minimize or reduce loss to follow-up. That is, don't miss an opportunity to treat screen positively. This may have a role to play in certain settings such as ours. The other approach is to wait for histological confirmation of disease before you offer treatment. Both methods have their merits and demerits. In the see and treat, in which a woman is screened and immediately she is offered treatment. In that case, the danger with that is that since you did not confirm the disease, there may be over or under treatment of women. In the other scenario where we wait for histological confirmation before treatment is offered, chances are that the woman may not come back for treatment. That means though she has been screened positive, but because she didn't come back, she's lost to follow-up. Now, various methods are also available for treating pre-malignant lesions on outpatient basis. The method adopted depends on the resources available locally as well as the expertise. Please, I want us to know that when we talk about outpatient management, it is strictly for pre-malignant lesions and not for invasive cancer, whatever the stage of that cancer. Even if it is micro-invasive, please. When we're talking about outpatient management of pre-malignant, we are talking about histological confirmed sign 1, 2, or 3. Please, once it becomes invasive, it is no longer qualified for outpatient management. Other factors to be considered including the patient's age, parity, preference, and desire for further childbearing, presence or absence of other medical or benign gynecological conditions. These are the factors we also need to consider. Destruction of the transformation zone, I said, can be done in two major ways. One, ablative technique or excisional method. In ablative technique, the abnormal areas are destroyed in situ. We destroy it right there and then on the surface. Whereas in excisional method, we cut, we remove, we cut off the transformation zone. There are so many types of ablative methods of therapy, but these are the common ones that we use: cryotherapy and laser vaporization. We don't have laser here, it's so expensive to maintain, and cryo is as effective as laser. So, but I've discussed cryotherapy today, while tomorrow, by God's grace, we discuss thermal ablation. Now, there are criteria before we offer any woman ablative therapy. The criteria are the lesions occupy. Hello? There's so much noise. The lesion should involve less than 75% of the transformation zone, less than 3 quadrants of the transformation zone. If we divide the transformation zone into 4 quadrants, the lesion should occupy less than 3/4. There should be no extension of that lesion into the endocervical canal. That is, the lesion must be seen in entirety. No extension into the canal, no extension onto the vaginal walls. And the cryotherapy where you're going to use, the probe of the cryotherapy must cover the entire lesion. That is, the transformation, the cervical junction should be visible in its entirety. And there should be no clinical suspicion or colposcopic evidence of invasive cancer. Strictly for what? Pre-malignant lesions. Now, cryotherapy is a low-cost ambulatory treatment and is as effective as any additional method to treat more pre-malignant lesions. It involves freezing the abnormal areas of the cervix using compressed gas. Usually we use nitrous oxide or carbon dioxide as the refrigerant. If you can afford it, nitrous oxide is better. The freezing is better and contains less impurities compared to carbon dioxide. The carbon dioxide is cheaper, readily available, but the one we see contains a lot of impurities. The impurities tend to block the nozzle of the cryogun. Now, the gas is forced through a very small hole at high pressure through the cryoprobe. And this produces a very low temperature of about -65 degrees to -85 degrees at the surface of the probe. The probe is applied tightly to the transformation zone. At this very low temperature, there is intracellular and extracellular crystallization of water, which is to cell dehydration, increase in concentration of salt, and release of enzymes and cellular destruction. Cryonecrosis or cell death occurs at very low temperature, -20 to -30. Now we use various techniques. With the cryotherapy, we can use a single freeze of 5 minutes or a double freeze. The one that is commonly used is the double freeze. That is,
Mute Ikechuku, please.
Now, the one that is commonly used, that is popular, is the double freeze technique, in which we freeze the cervix for 3 minutes, we wait for 5 minutes, allowing it to thaw, then refreeze for another 3 minutes. Freezing beyond this period does not lead to increase in tissue destruction. And with double freeze, studies have shown that we can freeze up to a depth of about 5 millimeters, which is adequate to treat most lesions. However, in our center, we discovered that there is a difference in the depth of freezing between anterior and posterior lips of the cervix due to the antiflex antiverted uterus. We discovered in the anterior lip, it was 5.2 millimeters in the double freeze compared to 4.2. Now, during when cellular distortions is going on, there is release of prostaglandins. Prostaglandins are responsible for the major side effects of cryotherapy, which is menstrual-like cramps. Overall, the procedure is not painful and is well tolerated. Post-procedure, about 20% of patients may experience watery vaginal discharge. Bleeding, infection is very rare with cryotherapy, as you can have infection if the man has a PID that was not treated before you apply the cryotherapy. So before applying cryotherapy, because of this side effects, watery vaginal discharge, the woman needs to be counseled that she is going to experience the watery vaginal discharge. And during that period, she should abstain from vaginal sexual intercourse. And if the couple cannot abstain, we advise them to use the male condom. This is because there was a study in South Africa that showed that there is increased risk of HIV transmission if sexual intercourse occur when the woman is experiencing the vaginal discharge. So the woman needs to be counseled for this, and she needs to inform her husband that during this period, after the treatment, you are likely to have these side effects, and when you have these side effects, please abstain from vaginal sexual intercourse. We don't want the woman to be turned into a punching bag. Now, long-term complications of cryotherapy are very, very minimal, and they may include cervical stenosis, but fertility is not impaired, and pregnancy complications seldom occur. Now, the main disadvantage of cryotherapy, like all ablative methods, is that there is no tissue for histopathological analysis. You cannot confirm what you treated, if it was a true premalignant lesions or not. We treated because we don't want that woman to be lost to follow up. However, you may take a biopsy before applying the cryotherapy. Mind you, the bleeding from that biopsy site reduces the effectiveness of cryotherapy, unlike when you are using thermal ablation. The next one I'm going to talk about is excisional method. And the main excisional method is LEAP for outpatient management. That is, we are cutting off the cervical transformation zone. It was a method developed by Walter Prendeville, though it has earlier been described by Katia. It involves the use of thin stainless steel or tungsten wire heated to a very high temperature to excise areas of the pre-malignant lesions. The stainless steel is attached to an insulated handle, which is fitted to the pen and pencil of electrosurgical unit, just like a diatemy. It is very easy method to teach, easy to learn, and easy to use. The main advantage of it has some advantages over cryotherapy in that the tissue excised can be sent for histopathological analysis that will confirm our diagnosis. Apart from confirming the diagnosis, if the margins of that tissue sent contain positive margins, that shows that our treatment is not completed. Also, LEAP can be used for lesions that are not amenable to cryotherapy. Lesions that have gone into the cervical canal can use LEAP for them. Sometimes the cervix may be distorted. The cervix may be distorted, making it difficult for you to use your cryoprobe. This is no problem when you are using LEAP. Now, in carrying out LEAP, These are the indications for to do lip. Either you have acetowhite lesions extending to the cervical canal, or your probe cannot cover the acetowhite areas, patient is HPV 16 or 18 positive, or the cervical architecture does not favor ablative therapy. The woman should be counseled on the procedure and on possible side effects and take informed consent. We ask her to remove all metallic objects from the body, including wedding rings, watches, and mobile phones. We assemble the instruments, and everybody in the room should put on the face mask. Not necessarily for COVID-19, but because when you are doing lip, you are using electricity to cut the transcription zone, smoke will be generated. This smoke may be generated. This smoke may contain HPV, which may cause laryngeal papilloma. So we ask the woman to lie on the examination couch after taking the consent. There's a return plate which will apply either to the thigh of the patient or to the back. Then you attach the smoke tubing, because smoke needs to be evacuated from the vagina, otherwise you will not be able to see what you are excising. We attach the smoke tubing to the insufflated speculum. Whenever we use insufflated speculum, so we don't want it to conduct electricity. After attaching the smoke tubing to the insufflated speculum, we pass the speculum to the vagina to visualize the cervix. 1% xylocaine with aniline is injected into the cervix. Then we apply 5% acetic acid and look for acetowhite areas. From the acetowhite areas, we determine the size of lip electrode to use, and we connect to the hand pencil. We put on the lip machine. Before putting on the lip machine, you do what we call a ghost passing. Put on the lip machine and set to cutting mode and excise the transmission zone. Takes under less than 45 seconds. Take out the specimen. You change lips machine setting to coagulation, and you change the electrodes to ball electrode and coagulate the bleeding points, usually at the edges of the cervix. Avoid coagulating the cervical canal. If the coagulation does not control the bleeding, you may apply Monset paste. The specimen removed should be tagged at 12 o'clock so that and put in label formalin containing specimen bottle. Specimen and remove the speculum. You counsel the woman about the side effects to be expected, and you document your findings. This specimen should be sent for histology. Observe the woman for about 30 minutes before discharging her home. Now, treating women with malaria is not enough. We need to do adequate follow-up to assess complications of treatment, efficacy of treatment, and to detect early recurrence of disease. This is important because early recurrence have been known to occur up to 20 years after treatment. In conclusion, treatment is an important component of cervical cancer prevention. If you don't have the means to treat, kindly, please don't screen women. For a cost-effective prevention of cervical cancer, treatment must follow effective screening with adequate coverage of women at risk. At least 80% of women at least must be screened to have an effective cervical cancer prevention program. And treatment must be proportional to the lesion detected. This is important to avoid inappropriate treatment. The cure must not be worse than the disease. Well, I want to thank everyone for listening to this short discussion. These are my references. Thank you very well.
Thank you, sir.
Thank you, sir.
You're welcome.
Thank you, sir.
Thank you. Welcome. I don't know if you have any question for me. I'll be glad to.
Great presentation, Prof.
Thank you very much, sir.
Welcome.
Thank you, sir.
Thank you very much, sir.
Thanks, welcome.
Thank you very much, sir.
You're welcome.
Thank you
I
very
have a
much, sir.
question.
Yeah. Okay.
Thank you very much, sir.
Yeah, I'm ready to
Yeah, I
take.
think we should listen to the question while we wait for Dr. Seji to get back on board.
Thank you very much.
I'm Dr. Agon.
Yeah, welcome.
Take your question.
Okay. I'm Dr. Chukwudensi from FMC Umahia.
Okay.
Please, sir, my question is, if someone has undergone LEAP and the results of the histology came negative for CA service, how often should the person repeat investigation for CA service?
No, what you said was that somebody did leave and the report came back as negative for CA service.
Yes,
Leave
sir.
never done for CA service. CA service is an invasive.
No. Yes. Okay. Let me start from the beginning. The initial results said high-grade squamous epithelial lesion. So the person was referred and LEAP was done to confirm whether the result was correct. Some parts of the service were removed and taken for histology, and the histology came back negative for any high squamous epithelial lesion. So my question is now, is it important to repeat investigation for? Yes.
I think you will need to discuss with your pathologist.
Okay.
Once you have seen high-grade lesion, then you need to discuss to review those slides.
Okay.
So we need to have a meeting with your pathologist to review the slides and try to resolve where discrepancies. Like you said, high-grade lesion implies a pap smear was done.
Yes, a pap smear
was that followed by colposcopy?
No.
I think you need to review the slides and the tissue exercise with your pathologist.
Okay, sir. Thank you, sir.
Welcome.
Thank you for the presentation.
Thanks.
Good evening, Prof. I have a question.
Okay, go ahead.
Yes, sir. Good evening, Prof. Thank you
madam.
very much for this wonderful presentations.
Welcome,
Dr. Halima from Gombe.
Oh, ready?
You're fine, thank you, sir. I just wanted to find out. I don't know. What do you do about orientation in after LEAP? You know, after you've taken the specimen between you and the pathologist. What do you do about the tissue orientation? Do you get to mark it, or what? Sometimes
what I do is that I tag it. I tag usually at 12 o'clock position. And I send it to it's the pathologist that will aim to know where if the cut margins are positive or not. My own is to tag so that the pathologist will be able to orientate the specimen. That's from usually I tag at 12 o'clock.
Okay. Okay. So the tagging, you mean you use a
I put the suture on it exactly. Yeah.
Okay.
At 12 o'clock.
Thank you.
Hello, Prof. Thanks for your presentation. The see and treat, the purpose of doing see and treat is so that we won't lose the women to work. But we found out that from experience, some of these women, even when you have consent form, for religious reasons, they cannot sign that consent form at that point of see and treat. They still have to go home and get consent from their husbands. So in such a situation, you might equally lose the woman to follow.
Madam, we need to, I agree with you, we need to counsel them And depending, we must be culturally and religiously sensitive to our patient
Yes.
needs. We don't, if a woman comes to our center to screen and she was treated, and in the process, that crashes the marriage, that sends a very wrong signal to the community. That the last time Mrs. O went there, her husband divorced her. Do you understand? We don't
Yes,
want to.
I know that.
Yes, so we really, that in such a situation we need to counsel more. We might even ask her to bring her spouse.
To come with the husband, yes.
Exactly. So sometimes in some culture, spousal consent is important. In as much you don't want any negative, like it was like they said, bad news spreads faster than good news. If a woman's marriage crashes because she came for a screen and was treated, other women will not bother to come. So we really need to set up a really tracking, a follow-up system, either with phone number, calls, and home visits. We do that in my center. Sometimes after calling the husband, it's the husband that will actually drag the wife to come and receive treatment.
So the screening in Nigeria in most cases is not very well coordinated, and also people screen and there is no treatment after screening, which is heartbreaking.
Yeah, which is very unethical. Nobody should screen without offering.
Even I've seen some sponsored by government and there is no treatment after screening.
Well, I think well, thank God, MWAN is a women organization. I think we need to inform our members that they should refrain from taking part in such exercise, that where women will be screened and she will not be offered treatment. We can disseminate that to our members, that before we take part in any government-based local government or state or whatever exercise, that we should ask, how do we screen? Because if you screen a woman, ordinary pap smear, and even if it's inflammatory, that woman that night will not sleep. She thinks, because the information, the poster usually put is that we're screening for cervical cancer.
Yes.
And we tell this man you are positive. What does that mean? That means she has cervical cancer. The next thing, she's thinking of she's going to lose her family, lose her life, lose her children. That night she will not. And now you're not offering her any form of treatment. That is an unethical practice, which I think we should tell our members.
I also think we should spend enough time counseling them, because the Nigerian factor comes into all these things. Let us tell ourselves the truth. They are not properly counseled.
Well, the screening, the screening equipment are not that expensive. For $1,500 to $2,000, you can get a good thermal ablation device that comes with a power bank. You can take it to any remote part. You don't need to have electricity to carry out treatment. We'll talk more about this tomorrow. The advantages.
Thank you, sir.
Over cryotherapy.
All right.
Thank you very much, Dr. Owa. Thank you very much, ma'am. I think I'll call Dr. There was somebody else that raised their hand.
Jonathan, Yemi, Jonathan, and Ejura.
Ejura, please. Ejura, are you there?
Yes, I am. Good evening, ma'am.
You're welcome.
Thank you very much for your presentation, sir. I appreciate MWAN for this presentation. It's been very, very informative. Thank you to all the presenters from yesterday. It's been wonderful. I'm glad I'm here. I have a question and a suggestion. I asked this question earlier during the course of the first presentation in the chat, but apparently it wasn't answered. I hope I can still ask it, and if I'm lucky, I can get an answer. I just want to know. Oh, sorry, I'm Dr. Eda Chaba from Covenant University, Ogun State. I want to know where a girl is not exposed to sexual intercourse early in life, does it make any difference to her, as in with regards to coming down with cervical cancer? In that, say, no, we talked about the girls receiving the vaccine from, I think, between age 9 to 15 or so from the second presentation on the first. And because that's the time they get to become sexually exposed for some girls. So where a girl doesn't get exposed that early, maybe much later in life, maybe like 20-something or 30-something years old, would it make any difference coming down with cervical cancer? That's the question. Then a suggestion, a recommendation I'd like to make here, because this is a good body. Regarding screening for cervical cancer and treatment or counseling of any sort, I think it would be good going forward for us to make it a family affair where a woman has an appointment with her doctor or she's coming to the hospital for the second or first time for follow-up, anything. I think we can incorporate the men, the spouses should be asked to come with them. So from the very beginning, both parties, the husband and the wife, will receive counseling, they'll be educated. Even in screening, the men too should also be part of it. They should come with their wives, listen to the talk, get educated, and work with them all through to the end. Just the way we encourage men now to be part of delivery and allow them into the delivery room sometimes, they get to have a feel of what the woman goes through. I think we can also make this to happen with regards to screening. This way, the woman will not be afraid or under pressure about going back to get permission from her husband or getting approval before she can be treated or go for any form of biopsy or something. That's just my suggestion or recommendation. Thank you, ma.
Thank you. I think
with regard to your question,
reply, yes.
HPV can be acquired at any time. That is very important. Even if if you look at recommendation by various bodies, even if you've been vaccinated with HPV vaccine, you are still encouraged to continue with regular screening. The latest HPV vaccine, to my knowledge, is the Gardasil 9, and we have about 13 oncogenic HPV serotypes. So that does not cover everything. In fact, one of the serotypes that is very important in our setting is the HPV 35. The Gardasil 9. Neither Gardasil 9 nor the original Gardasil Ocevaris covers HPV 35. So if a woman has had the vaccines, she's still encouraged to continue screening for cervical cancer. Like now, if HPV can be acquired at any time, just that in the teenage years, due to the modeling going on and the first pregnancy at the cervical transmission zone, that makes her to be what? To be highly susceptible to to HPV virus. At any age, it can be. Does that answer the question?
Yes, I think so. So this means delayed sexual exposure makes no difference.
Reduces the risk. Reduces the risk.
Okay, reduces the risk. Okay.
Significantly.
Thank you.
Yeah.
Okay.
Thank you very much.
Like the last speaker said yesterday, one of the lecturers, she said, sexual intercourse within 1 year of menarche increases the risk by about 26 times compared to when it takes place years later. The risk is not zero, but it's significantly reduced if sexual debut is delayed.
Thank you, sir.
Welcome.
I have 3 people with their hands raised. So because of time, we will take the 3 of them. Dr. Yemi Jonathan, Dr. Adamu, and Dr. Bilkisu Abubakar. So let's start with Dr. Julie Yemi Jonathan so that we can go through quickly. We don't have too much time. Thank you very much.
All right. Good evening, everyone.
Good evening.
Yeah. Good evening. I want
Hello?
to especially thank MWAN Yes, I know.
Hello?
Can you hear me?
Yes,
Yes,
I can hear you.
Thank you, Professor Ajano Fuja, for your presentation.
Thanks,
My
Uzoma.
president is having problem with her network, and she said I should stand in for her.
Okay, thank you.
Thank you very much for everything. Ajano Fuja, it's so nice to see you. It's a long time.
Thanks, Uzoma.
Thank you. So we're going to be wrapping up right now. I
Okay,
thought we still have time to take more. I'd like to take your
somebody
questions.
is asking a question, please. Somebody is on the line. Is asking a question. Somebody is asking a
I'd
question.
like to take your questions.
Yes.
We had 3 hands raised, so we wanted to just take those 3. Someone just joined in now.
Mrs. Julie Yami Jonathan, please go ahead.
All right. Okay. So thank you, Professor Ajano Fuja. And maybe just to add that someone said that there is no treatment program in Nigeria. Fine, MWAN is doing a lot with respect to massive and population-based screening. But I think across the country, and Professor Ajano Fuja, even Professor Uzoma, can also attest to the fact that TRI, being funded by UNITAID, is currently implementing the cervical cancer screening program in 3 states in Nigeria, in Kaduna, Lagos, and Rivers. So in Rivers, we're currently in 50 program sites across 19 LGs, and all 50 sites actually do treatments using the thermal ablation. And then we have about, I think, 15 sites that do lip services. We also even provide colposcopy services for clients that have HPV positive for high risk subtypes, like the 16, 18, and 45. So yes, there's a lot of, it's quite minimal, and you can see in the data, it says about 9% coverage in the country, but at least this is a start. And I'm sure that with this 3 days webinar, there's a lot of awareness and sensitization that will go on with cervical cancer screening, and we'll see how we can increase the numbers and reduce, and at least we can move towards the roadmap with the WHO elimination goal of over 70% prevention and screening rate. So yeah, thank you, Professor Ajano Fuja.
Yeah, thank you.
I'm currently working with TRI in Rivers State. So
Oh,
yes.
that's nice. So there's one thing I forgot to mention. When we are carrying out sleep, it should be done under colposcopic vision. Thank you.
All right, thank you, sir.
All right, so
please, I also have a question.
Okay, all right.
Dr. I heard you now. Dr. Adamu.
I raised up my hand. Okay, thank you.
All right, but Dr. Adamu, please speak. Zaiha to Adamu. Are you there? Unmute your mic. We don't have much time. Should I go to the next person? Dr. Bilkisu Abubakar.
Yes.
Are you ready? Dr. Adamu?
No. Yes, I am. Good evening.
I'm ready.
Good evening.
I'm ready. Good evening.
Hello.
Go ahead. Go ahead.
Dr. Adam is on. Dr. Adam is recognized.
Well done, Professor, with the presentation.
Okay, Dr.
I'm
Adam.
not midwife. I have to add on.
Okay.
I'm not a doctor.
All right. No problem. Continue, ma.
I have a client in our unit, Precious for CA. The result of pap smear was high-grade lesion, and she was taken for the biopsy. And the histology result also came back with cervical intraepithelial neoplasm type 3. So, and the woman, she is complaining of pains and then bleeding since before that procedure. So in my suggestion, I think maybe she will go for hysterectomy or lip procedure.
Why are you doing hysterectomy
That's
for
my
her?
question.
Madam, why are you doing hysterectomy for her?
Hello?
What is she
Why are
to
you
do?
doing hysterectomy for this lady?
She is suggesting that because she don't want it again, because she was disturbed.
about the...
No, madam, please, like I said, hysterectomy for, if it is truly pre-malignant lesion, hysterectomy is an overtreatment. You have means of doing lip for her.
Yes.
My concern is that she may have what? She may have a higher grade disease than what histology showed. Because the cervical pre-malignant lesions, they don't have symptoms. By the time the woman starts having symptoms, it's likely she has invasive lesion. I think you will need to have a look at her again. Because if you do simple hysterectomy for her and she has an invasive lesions, that's an under treatment for her. Another thing again with some of these women is that even if it is in 2 or 3 and you do hysterectomy for them, they think everything has been removed and they will not come for follow-up.
Okay. Thank you, sir. Thank you, Prof.
Thank you,
Agile.
sir.
Okay, do we have any more questions?
Yeah, Bilkisu, Gulma,
Abubakar.
Good evening, all. Thank
Good
you,
evening,
Prof.
madam. Yeah,
Thank you, Prof, for the presentation.
welcome.
Can women who are over 26 years of age with no history of sexual activity whatsoever be advised to take the vaccines?
Why not? You can't take the vaccine. Vaccine can be given at any age, but it's best given before a woman initiation of sexual intercourse. Because if the woman has sexual intercourse, the effectiveness is reduced. These vaccines, they are prophylactic. They are not therapeutic. They will not remove the HPV that the woman already has. They can only prevent her from acquiring any vaccine that she has not already had. If she has not had sexual intercourse, yes, you can take the vaccine.
Okay. Thank you, sir. Is Dr. Eson still there? Dr. Eson, it's like she's out. Ramat Kawu, please ask your question. Ramat Kawu, please unmute yourself and ask your question. Okay, it's like she's out. Dr. Mamadou Amina. Dr. Mamadou Amina, please ask your
Thank you very much. Thank you very much, Prof, for the lecture. Please, I have 2 questions. My first question is, after cryotherapy, since no tissue was taken for histology, when next will the patient be screening? And my second question is, after VIA-VLI, the patient is adjudged to be negative. What next? Can they not take the vaccine? Thank you very much, sir.
Now, when after cryotherapy, usually we see the woman between 6 to 9 months to re-evaluate her. Depending on the local policy for cervical cancer screening. If you treated her, see her again for 9 months and examine the cervix. Then she will come for screening maybe a year or 2 later. Now, if a woman has done VIA or VLI, or even pap smear, and they all turn out to be negative, that does not mean she does not have HPV. Because the cytology, pap smear, VIA or VLI, they are looking for what? Morphological changes on the cervix. The HPV may be there and is not causing any problem. That does not mean it is not there. The mere fact that VIA or VLI is negative does not mean the woman does not have HPV. Is that clear?
Yes, sir, it is clear, but can they now proceed to take the vaccine?
What I'm saying is this. The vaccines can be given to anybody if she has the money. But when we're talking about public health, using public funds, the vaccines are best given before sexual debut, before sexual intercourse. If you have the money, you can take the vaccine at any age, but the effectiveness reduces if a woman has started having sexual intercourse.
Thank you.
It is effective if the woman does not have that type of vaccine, that type of virus that is in the vaccine. It's effective for. But if she already has HPV 16, 18 or so, giving her the vaccine will not prevent her from having those HPV types. It is not recommended to screen a woman before you give the vaccine.
Okay, sir. Thank you, sir.
Thank you, sir. I think we have answered all the questions.
Yeah.
People that raise their hands. Professor Aguma, please. I think you said Dr. Seji gave you permission to talk on her behalf. Professor Agum. Okay. I know she's here, but it's like she's not. Well, in absence of her presence,
I'm
okay,
here.
she's here. Yes, ma,
Yeah,
please.
I'm in 2 meetings. Okay, so thank you very much, everyone, for taking out this time to be with us today. Tomorrow is another day. Thank you, Professor Ajene-Fuja. Thank you, Professor Jonah. We're happy that you gave us your time. I think we should all go and rest, and then tomorrow we'll go again.
Yes. Thank you, everyone.
Good night. Bye.
Bye.
Thanks, everyone.
Thank you very much.
Thank you, everyone.
Thank you.
Thank you, everybody. See you tomorrow, God willing.
Can we get the slides?
Let us put it into practice. So, not be to listen to lecture, be the matter, not to practice. So,
your time.
Thank you,
everyone. See you
And the
tomorrow.
slide is sent
Thank
to our
you.
email.
God bless us.
Thank you, everyone.
Thank you. Thank
You've
you.
been
Can we
fine.
get slides in our mails?
Thank you,
Tomorrow
everyone.
we will share a link of it.
Everyone.
We need the slide in our email.
Thank you.
Thank you,
beginning
everyone.
of the long road to cervical cancer elimination in Nigeria.